Thank you again. We've got just a terrific panel. I know there's a lot of conversation. We've seen a lot of questions coming in. So I'm going to hand this over to our Bay Area chapter, Eleanor Pepples, to introduce our panelists and to get the conversation going. So thank you again, everyone, for joining us.
Fantastic. Thank you, Rachel. I am quickly going to share one slide with you all, just so you have a sense for who we are. So the Yale Alumni Nonprofit Alliance brings together the social impact world. We try to connect and catalyze for global good. And today's program, I think, epitomizes the work we do. Again, I'm Eleanor, and I run the YANA outpost here on the West Coast. We serve all of Northern California, and we endeavor to create programming and events that support our community's needs, as well as to reach more broadly, nationally and internationally, on these critical topics. And today is certainly one of them. We're looking at advances in mental health. We have, as you can see, a star-studded cast. I am incredibly delighted to have with me Mary Giliberti with the Mental Health of America, and also Margaret Laws with HopeLab out here in Silicon Valley. And I guess, Mary, you're in DC, right? Washington, DC tonight. Great. And then Philip Corlett, he's a PhD, so I guess I'll say Dr. Corlett, and here Dr. Hilary Blumberg, also from Yale. So we have so much to cover today. I think I'll start with our Yaleys and also ask broadly to all of you. So much progress has been made in terms of understanding of mental health broadly. My question for you is, what can we do better? So take it away, Hilary or Phil, who would like to? Dr. Blumberg or Dr. Corlett, where would you like to go with this?
Maybe I'll start very briefly and just, thank you for including me on this panel tonight. And so I think on the one hand, there has been a lot of terrific progress, and a lot of it at Yale, but also at many other places. And so I think it really is very important to highlight how much progress has been made and the great hope that goes along with it, that new ways to diagnose and treat, et cetera, and relief are on the horizon. That said, what else do we need to do? I think the answer is yes. Just about, pretty much from A to Z, we really could use, more research, more clinical services, more connections between both of those. And I think I probably could go on and on with those, but maybe I'll hand it to Phil and see if he wants to continue.
Oh, happy to. And thank you again for having me and having us. This is such an important conversation, and I'm so glad that Yale can be part of it and that we can represent our department. We have a pretty successful department. We bring in about $90 to $100 million of NIH funding every year. That's in the top 5 departments in the country, sometimes the top department in the country, depending on how well our year goes. That's not enough, though. And to answer your question directly, taking the work that we do within the department and translating it into the clinic is the hardest part. And it's the part that isn't facilitated or supported as well by the NIH. So we have a colleague here who's in Silicon Valley. I started a mental health startup We were just accepted to the OneMind Accelerator, also based in San Francisco. 10 companies made it into the inaugural program, which brought some funding and some training and some guidance from world experts into exactly how we can take what we've learned and bring it into the commercial realm, which then facilitates that translation directly to patient benefits. 4 out of the 5 startups that made it into the accelerator were from Yale. So not necessarily from our department, but Yale grads were CEOs or C-level executives as part of the program. And I just think that's pretty impressive, right? We're doing something right in how we're training our younger Yalees and how us members of the department are sort of seeing a path forward and really seeing a gap in how we achieve this translation. It's not the only way to do it, but I think it's the way that we can do it the fastest. And it's really about, as I mentioned, forging links between entrepreneurs and scientists, which I think will lead to exciting things.
Fantastic, Phil. Do either of you want to speak directly to some of the initiatives that are going on at Yale broadly, or you mentioned some in your own arena? Hilary, do you want to just speak sort of briefly? I mean, you're doing so much, both of you, to some of the work you're doing around mood disorders and sleep and goodness, the panoply of what you're contributing.
Absolutely. So I guess as I've been at Yale almost, Yale as faculty, the medical school almost 25 years. So I suppose over time I've accumulated different things that I'm doing. But as you mentioned, I'm director of the mood disorders research program. So that's my focus. As you know, as Phil mentioned, it's really astonishing kind of the breadth, and then within that the depth, throughout the department. But I could speak, particularly to mood disorders. And for example, in my own program, which is really kind of the tip of the iceberg at Yale, really, we focus on mood disorders, so bipolar disorder, major depressive disorder across the lifespan. So in kids who might be at risk all the way through older individuals. And we also have a focus on preventing suicide. And some of the areas we're looking at are, we do have some focus on studying brain circuitry. This is also something that Phil is super expert in. And we look at some of the structure and the function of the brain circuitry in the mood disorders. We're very fortunate to have great state-of-the-art brain scanning techniques and analytic and computational techniques. And in addition, we kind of go I think kind of the gamut all the way from looking at drilling down to some of the most basic mechanisms. So we look at, for example, genetic and molecular mechanisms, and we do that through genome-wide study. And also, more recently, some of the work of my group and other groups is now to be looking with new stem cell technologies to be able to generate from just a blood sample, not just pluripotent stem cells, but neurons, so brain cells. It's really the first time in psychiatry that we can actually look at the functioning and the physiology of someone's brain cells and what medications they may respond to while they're alive. So this is something that I think may help to revolutionize some things in psychiatry. And so with some of these molecular things, we're hoping to get at critically needed biomarkers and discover new and improved treatments. But then kind of we kind of go all the way through at Yale. And on the other end of the spectrum, we're looking at behavior. And that could be in particular, quite important, especially when we think about having global reach and finding ways to help in ways that are low cost and disseminable, and helping to empower individuals also to help themselves while, unfortunately, wait lists are long and we have to solve, the crisis of access to care. And there, I think, and Phil kind of alluded to this, is that many of us are involved in the use of digital technologies. and finding that those are really helping us to transform things, because it used to be kind of in mental health and psychiatry, you might look at someone at one point in time and the information is very limited. Now we can look at them over time and even get really kind of detailed about that. And that's showing us patterns of behavior. And some of the things that can help us to do is to find ways, for example, with digital technologies, to detect a change in someone's behavior really early on. That could then, we can intervene to prevent worsening or prevent suicide, and also help give individuals more information about themselves. And then I don't want to monopolize the time here, but we could keep going, because there's also work all the way through to working closely with the local community, with national and international community, and trying to help with policies and so forth.
Yeah, I agree with everything. I'm just going to yes and what Hilary says and give you a few more details about exactly how we get to do that. So one specific program that we've been extremely fortunate to be involved with is the donation from Joe and Clara Wutsai to start the Center for Human Cognition, which is really a sort of landmark investment. There hasn't been anything quite like that, with such a focus on how humans think and trying to understand how humans think from these three important pillars that Hilary's alluded to, which is cognition, computation. So how do we achieve the thoughts that we achieve, and what are the sorts of operations that we use to have ideas and form beliefs and change our minds? How do those things develop? So from childhood through adolescence and into adulthood, and how can we model those in computational architectures? Can we build algorithms that think like humans, and can we use those to come up with new ideas about how to treat or perhaps even prevent mental illness before it begins? There isn't a specific focus on mental illness, but psychiatry is a huge part of the Wutsai Center. I'll be moving my lab over into the new building and sort of embedding a focus on the range of things that people believe and perceive and experience. Because somebody dropped a note in the chat, which I fully agree with. When we talk about mental health, we're all talking about lots of different things. It's not necessarily just mental illness. Mental illness I see as something on an extreme end of a spectrum, and we all fall on that spectrum at particular points. And so as we learn more and more about the brain and the mind and how those things kind of contribute to one another, we're going to be in a much better position to bring that new knowledge to bear on the problems of mental illness.
Thank you so much, Phil. Well, what a natural tie-in to some of the work that Margaret Laws is doing with HopeLab. It's just remarkable when you begin to look at the intersection of tech and mental health, how much progress is happening there. Could you speak a little bit to some of the advances that you think are going to make just a world of difference in people's lives?
Sure. Well, I'll start. First of all, thanks for having me. Really exciting to be part of this group. I think I may be the only non-Yale on the panel, so thank you all for including me despite my my other school affiliations. I want to say just a little bit about what we're doing at HopeLab, because it does tie in actually both to what Hilary and Phil spoke about. We are San Francisco based. We were founded and are funded by Pierre and Pam Omidyar, founders of eBay, and we're an impact investor and a social innovation lab, along with a translational research arm. So we have sort of three things we do at HopeLab, all focused on the mental and emotional well-being of teens and young adults, with a deep focus on BIPOC, LGBTQ+, and other underinvested groups. And we have HopeLab Ventures, where we are a mission-focused investor. We invest in companies, the companies like the ones in the One Mind Accelerator, Phil, that you're talking about, that have a emphasis on mental and emotional well-being of young people, all the way from very clinical companies on one end to much more social, metaverse things, because we work so closely with young people, emerging tech ways of approaching mental health and well-being, music, entertainment. We have what we call HopeLab Studio, which is our social innovation lab. We have a team of designers, researchers, and digital product folks, along with a youth lab. And that group works with the companies in our investment portfolio, as well as with nonprofits around the country, to really try to bring principles of human-centered design, youth input, research, things like impact pathway, ways to think about what the impact pathway of this intervention is going to be, to those organizations we work with to try to accelerate their success. And then the third area we call HopeLab Discovery is really focused on translational research. And there, what we're trying to do is something, Phil, you talked about, which is to make links between entrepreneurs and scientists, and to really try to make sure that the science that's going on out there in the labs and with researchers around the country in the area of teen, young adult mental health and well-being is getting translated into the products and services that are available to young people, whether those are in youth development programs around things like developing, nurturing a sense of purpose, to science, brain science, and getting neuroscience and brain science into these interventions. So that's what we're doing at HopeLab. I have a long history in health and in digital health. I've worked in really trying to bring innovations in healthcare services and technologies to underserved populations, Medicaid, BIPOC, LGBTQ+, other underinvested and underserved groups. And so the focus right now at HopeLab on teens and young adults is a particularly interesting one, because what we're really trying to do is to think about, what are some of the roots and some of the causal factors, or I would say contributing factors to high levels of youth distress, whether that's increased levels of suicide, increased levels of depression and anxiety. I mean, across the board, these numbers are bad, and they're significant challenges, particularly for low-income groups. And so we're trying to really take the approach of bringing youth leadership into the space and having the entrepreneurship and the understanding that young people have around the new technologies and the new spaces where a lot of interaction of young folks is going on. One of the examples I'll give, because I think it'll be a nice tie into something Mary might talk about in policy, is peer support. So we know that almost 70% of young people, the first person they talk to about their concerns with their mental health or some distress around mental health is a peer. And so we've been thinking a lot about how do we support peers in supporting their friends. There's lots of programs that we work with and support, from Active Minds to Bring Change to Mind to MindRight, which is a company in our portfolio that really focus on equipping and supporting peers to be supporting their friends and really creating a community of support around young people. And one of the reasons that so many of those peer services are possible is because of changes in policy and reimbursement that allow for peer support, not just licensed clinician support, to be one of the modalities that can be used for supporting the mental health of young people. So I'll stop there. I'm happy to talk about anything of specific interest around tech, teens, mental health, but I think it might be a nice tie-in to Mary's incredible wealth of resources and knowledge from Mental Health America and from her career.
Wonderful. Mary, I would love for you to introduce yourself, some of the roles that you've had in mental health. And then I guess I really have two questions you can address in whatever order you like. Thinking about young people, especially young girls, how they seem to be experiencing, such high levels of distress and suicidal thoughts. What sort of policies can make a difference, what supports can make a difference. You have an amazing website that can help in terms of individuals either diagnosing themselves or families looking at that, and how do you protect individuals, and goodness, and then you sort of look at substance abuse and supports there. I mean, and the gamut, the spectrum of so many different mental health needs. So there you go. There's sort of asking for the moon. And then, more specifically, what are the most impactful policies that we could enact to address the mental health crisis that we're experiencing? How's that, Mary?
That's a lot. But let me start off by just saying that I am the Chief Public Policy Officer for Mental Health America. And for those of you who may not be familiar with Mental Health America, we are the nation's oldest mental health advocacy organization, founded by a Yaley, believe it or not, tying in here, Clifford Beers, in 1909. And Clifford Beers had a mental health condition and was hospitalized and experienced abuse, and wrote an autobiography about it and did tremendous advocacy. And his phrase that he had to use was, I'm going to fight in the open. And I think our organization continues that motto today. Going to Margaret's point about peer support, we still look to empower the individual and the person who is going through a mental health journey. And some of that empowerment is often through peer support, because who's better equipped to help you navigate and do what you want to do, discover your own goals, than someone who's been through it before. So that's a real core tenet. We do a lot of work on peer support. It is a very impactful policy. We try to get resources for it. I've been working in the past year to get Medicare to cover peer support services because Medicaid does, but Medicare does not. And like almost all mental health services, vastly under reimbursed, low reimbursement rates, a big problem. If you want to say to me, like, what things could make a difference, we definitely need to address the longstanding problem of discrimination. And I think my own pathway to this work, which I've been doing now for about 30 years, since I was a Yale Law student, and it is Yale Law School that brought me to this work, because I thought I wanted to represent children. The only clinical program was in disability law, and I started representing people with mental health conditions, trying to get Social Security disability, being restricted in the kinds of things they could do when they were hospitalized, children who needed services in special education. And through that work at Yale Law, I saw incredible injustice, discrimination, lack of caring about what people actually wanted versus what the system wanted to give them. And to this day, that motivates a lot of the work that I do. And I still see some of the same things that I saw back then in terms of undervaluing these services. They are tremendously undervalued. The quality of services, and by quality, I mean not only the type of therapy and getting therapy that has been well researched, but also your own experience, the person's experience, and really counting that, caring about what is that experience. If any of you have been through mental health treatment, you know that sometimes you're not treated well. And that needs to be a core in how we do public policy. So one of the things I've been working on, I'm sure most of you don't know that when you go to a hospital and you're hospitalized, you get a survey afterwards. But there's only two groups of people that don't get a survey after they're hospitalized. One group is people with mental health conditions. The other is people who are dead. So we see discrimination, blatant discrimination, continuing in mental health policy. And so we need to address that. And then we also see disparities. So that discrimination is even more pronounced for some groups, for people of color, for example, for LGBTQ plus youth. We see disparities in access to care. So if you look at the percentages of people who are getting access to care, they are different. And that is a major problem too. And lack of culturally responsive care, or people that look like you. So that goes back to peer support. You might want to be served by someone who understands your background, what your community, and peer support's often able to be that kind of support, but we don't pay for it as well. Private payers really don't pay for it at all. Medicare doesn't pay for it much. So we need to do better in taking a more equitable response to mental health care.
And one thing I'll jump in with really quickly, just to piggyback on what Mary said, is, one of the things that we think about when we think about technology, peer support, AI, a lot of things that are undercurrents of a lot of this is access to support. And I think if we're, one of the biggest questions we get from both, at least I do, from friends as well as from people whom I interact with professionally, are around how do I get access for my child, my friend, my colleague. And I think we do have a real, if we're relying on, and I'll toss this back to people who work more in the clinical realm, but if we're relying on clinicians to provide all of that support, we're going to continue to have really incredible shortages. So I think one of the things that we're trying to focus on through how we deploy technology more effectively is what is the combination of sort of human touch and technology that can provide people some of the supports that can help them, recognizing that we just don't have enough licensed clinicians to be dealing with all of the mental health challenges we have right now. So I'll throw that access question or thought out to the group, because it feels like that's one of the, I hate to talk about it as superior or inferior care. I think there can be places where peer support and where technology-aided support can be the right thing for the right person at the right time, can be the right intervention. But there's a lot of controversy about it, and like a lot of disagreement about whether solutions that are not one-on-one therapy are good solutions for people.
No, I think that's a really important point. I think you're right about the young people. I think they've been raised as sort of digital natives in a way that I wasn't. I'm older than I look. And two of the companies in the accelerator, not to keep talking about the accelerator, but two of them are trying to create peer-to-peer networks for youth mental health, and having astonishing success. This is something that young people want to do. It's something they want to be a part of. I think it's something that perhaps the pandemic has facilitated for all of us. I think it's led us to be much more comfortable with this sort of a venue. There's been a flourishing of CBT being delivered through telehealth, for example. But like you said,
Phil, can I just jump in for those who might not know what CBT is? Can you just mention?
Absolutely.
I'm going to keep catching any of you on acronyms, because I really think the audience is engaging anew in this. So thank you.
Not YANA. I thought they knew all the acronyms. So CBT is cognitive and behavioral therapy. So it's a therapeutic approach that's been developed by the work of Aaron Beck, who sadly passed away last year. And it's really a way of thinking about how teaching people techniques where they can reframe their appraisals of their thoughts and their emotions, and sort of challenge some of the ways that they've been thinking about their thoughts and emotions, and perhaps replace them with alternative, more adaptive, or more helpful viewpoints. So it's a course that could be delivered via a therapist, but in recent years, that's started to either be via Zoom, but by connection to an actual therapist. And there are even companies that are trying to, and labs that are trying to develop digital CBT through chatbots with some success.
So, Mary, going old school, we can look at the role of social media, I suppose, positively and negatively. And you had mentioned something fascinating the other day in regard to the triple digit number, 988, and how there can be an interface when individuals who are struggling ask very difficult questions around some of their dire thoughts, and then they receive a barrage of very troubling response from the internet. So would you speak to that? And then also, the tremendous value of that 988 number?
Sure. That is a recent development. So the 988 part, we've had a suicide lifeline for a long time, but 988 came into being last July. And just like you call 911, you can now call 988. You can text. And I know text, I can just say from my own experience, my son had a friend who was struggling, didn't want to call, but was willing to text. So there's chat, there's text, and there's call. And it's so much easier. I mean, like I said, I've been doing this for 30 years. And if you asked me to come up with the suicide hotline 10-digit number, I couldn't do it. But I can remember 988. And so can everybody else. So, you know, please, if you take nothing else away from this, remember those numbers and tell people about it, because it's really important to have a mental health response to a mental health crisis. And too often we wind up with a law enforcement response. And that's really problematic and can often cause a lot of harm. So I really want to encourage people from a public policy standpoint. We are now working state by state to get some of the resources to fund the call centers. We work federally to get resources to fund the administrator and to fund the services that are needed. If someone needs someone to come out with perhaps what we call a mobile team, which is often a peer and a clinician who can come to you, comes to the house and tries to help. That's very rare. A lot of times they can just resolve things on the phone, but that's another service that we work very hard to try and make sure is available in communities, but there's a lot more work to do there. But 988 is a really important development. I think one of the problematic things is not everybody knows about it. And certainly we haven't done the outreach to all communities to make sure people can make the best use of this line. Another resource that I just want to touch on quickly, because we're talking about things that people can use in their everyday life, is on our website at mhanational.org. We have information if you need help. It says, you know, find help for me. And it goes through, if you just want wellness resources, we have that. But a resource that I really want to emphasize is our screening program. So it's an online, we don't get any data about you. We don't ask your email. We don't want to know anything really, except we ask some demographic questions that we use for research and for public policy, but they're not identifying. So what we have these tests, and you can take it in depression, anxiety, psychosis, whatever you are worried that you might be experiencing, because so many times people aren't quite sure, you know, is this really something I should be concerned about, right? And the tests that we have up there are well-validated tools. And you take that, and then we don't diagnose you, but what we'll tell you is, yeah, you might want to go find out more, either get more education, have a tool, like a digital tool, we have some of those. Or if you want a referral, we have some resources on how you can get treatment. So we kind of help you figure out how to think about next steps is really the way I think about it. And we have one for parents of children. If you are seeing things with your child, but you're not sure if that's something to be concerned about, you can take that and then get some ideas about next steps. So I just want to highlight those two resources. One is sort of when you're in crisis and you really need to chat with someone, and the other is more when you're not sure what's going on and you just want to know, what should my next step be?
And Mary, I have a follow-up question for you. We talked earlier about the need to keep pitching questions around between the panelists, but I need to come back to you again. In thinking about individuals with mental health who can be referred to as people with disabilities, thinking about their families, some of the things you were mentioning. There is, of course, the challenge of deciding that your reality might be different for someone else's, understanding that your challenges might be of a different range of experience. So that's in the individual's own right. Then you have family, where the question might go to acceptance. Do you notice it on the one hand? Are you aware that your child might be experiencing something significant? And perhaps you might. Or you might think it's there but not want to see it. So that sort of question around embracing difference. And then even, so that's a deep question. And then I guess protections, it's hard to understand the fear that still exists around mental illness, both from those who have it and from families, from friends, from schools, when in fact, I think when you look at it, just as you might a broken arm, or better yet, a condition, and any individual might live with. Can you enlighten us a little bit there?
Well, I guess I would say that, going back to your point about how people feel about this, and that they worry a lot about disclosure and worry, they don't always even know that they're protected by civil rights laws, right? Because if you have a mental health condition, you don't always realize that many times is a disability covered under protections, right? So you have some protections, but you might not even know that. So I think that going back to your point about like, how do you accept people? I always am a big believer in mental health education at all levels. So we've been working to support mental health education in schools. New York, for example, has a requirement, K through 12, mental health education. I think what a world it would be if everybody were educated from young about, mental health conditions, what they are, how to look them, how to support somebody, and that supporting is really important to me, because I wasn't a good support for someone very close to me in college. I had a college suite mate who had major depression. I didn't know what to say. I said everything that Mental Health America would tell you not to say. Cheer up, look on the bright side. We're in college. There's all these great things to do, right? Things that family members say that they shouldn't, things that friends say because they don't know any better. And my college suite mate eventually died by suicide. And so it has really been something that's really important to me that people learn. And there are programs. There's mental health first aid, for example, that you can educate yourself. There's curriculum that we can do better. I mean, every state in the country should have K through 12, skills building, and then also mental health literacy. Those things should be combined, and everybody should have access to them, so that not only yourself how to promote your wellness, but also how to help somebody else, and how to be the right support, because that is very, very important, as you said. And many times it's because people don't know. And so we really need to educate ourselves.
So in terms of that education, do you suggest people go to, for example, parents, do you go to the U.S. Office of Education and look at the Department of Civil Rights tab there, or look at FERPA? It's very hard if you don't know what's out there. How do you know what to ask?
Yeah, I think
families. One more second. How do families access the system in terms of, what do you need to get your child accommodations? I mean, you need a neuropsych evaluation. How would you even know that if you didn't have some kind of network? And those sorts of accommodations can create an absolutely level playing field so that people with disabilities can make fantastic contributions. And then I'll have a follow-up question.
Margaret, I'll let you go ahead and chat. I know you put in the chat some resources.
Yeah, well, there's one I put in the chat, which I think is really interesting, Eleanor, vis-a-vis that particular question. Child Mind Institute, there are many of these, but Child Mind Institute has parent-specific resources for parents on both mental health and learning differences and neurodiversity for young people. And that is all going to be made available more broadly. It's free and available now, but the state of California and many other states have been investing a lot in child mental health. And so one of the things that's happening in California is an online platform to support health and well-being of mental health and well-being of young people. And that will have resources for young people by age cohort, as well as for parents. And so specifically to that question, I would say that's a good starting place. There are also, I think I think Rachel is chatting out the things we're putting in our panelist chat to everyone. So Mary, I don't know whether on the MHA site you have resources for parents as well. I suspect you probably do. And I'll say there's also through Bring Change to Mind and Active Minds and a number of other organizations that have chapters in high schools and colleges. There's been a lot of sort of work really just to try to get out both destigmatization in schools. So making sure that people in schools feel like they have places to go to talk about what's going on with them, as well as just to make people have resources be more available to more people through the public school system. But Mary, I'll turn it over to you for MHA on this topic.
Certainly, I think they put the MHA website in the chat. The National Alliance on Mental Illness, also NAMI, has family information across the age spectrum. So that's another good resource for families as well. And I also go to the NIMH website quite frequently if I'm interested in information about particular conditions and treatments. So that's another very reputable place that you can go. And SAMHSA, the Substance Abuse and Mental Health Services Administration, also has resources for families. They have a treatment locator that can help you find resources in your area. So that's another resource for people who are seeking help.
Fantastic. Dr. Blumberg, would you talk to us a bit about some of your work with sleep and the difference sleep can make, and then also routine for individuals with mood disorders, and perhaps some of and I know Phil was alluding to it, Dr. Corlett, in regard to emotional regulation, how basically just sort of different tools for going through life in such a way that you can make the most of it.
Yeah, so thank you for the question. So I think thinking about sleep and daily routines and what an individual can do is sort of one example, and a hopeful one again of where we now even have research evidence that someone learning strategies and to help healthy types of strategies and behaviors, they can actually do a lot of good for their own brain health and mental health, and help to reduce symptoms and maybe even prevent some, and in some of our work prevent suicide. So one of the areas we've been focused on is especially in teens and in adolescents and young adults with mood disorders and other disorders, how sensitive so they can be to routines that are messy, and kind of changes in sleep time. I think everybody's kind of potentially experienced what it's like to have jet lag, and you have that change in these 24-hour circadian rhythms and sleep rhythms. And there's sort of a spectrum of how people can feel, but people can feel quite badly or irritable. And so it's really an example of how much the brain can kind of change. And then at the same time, people get over jet lag. And so it's temporary, and there are kind of ways to get things back on track and to change things. So what we and others have found is that by helping individuals have more regular daily routines, that it can be really robust in reducing some mood and other symptoms, and also suicide risk. And just to kind of say what I mean by the routine, so sleep time is super important, but you can't really just tell someone, try to start to go to sleep at the same time each night, or try to get up the same time each morning. That really doesn't work. But what we found is that if you kind of go through the day and see what changes you can make in your day and kind of chip away at the day, what can be a little bit more regular? What can you do? Can you see the same person each time in the morning, or have a little routine, in the morning that can kind of be regular? Can you kind of get, what time you have lunch or a snack? Can people that you live with help to have dinner at the same time? Your body's getting all these kinds of messages about the 24-hour patterns, and ultimately you can actually find that you can sleep at better times, and the body likes all these kind of things in homeostatic control and regularity, and it's really strikingly robust in terms of improving mental health. So I think it's kind of a nice example, even when we think about, I think there's been a great discussion of how critically important the peer interactions can be. And these are kind of, things that, peers can, try on for themselves, be, convince for themselves, and then, kind of perpetuate it and teach, other peers, and teach, other people to try to help things. So we have kind of the more of a structured therapy that we're doing in our research, but really these kind of ideas about regularizing daily routines, there are things that we could educate about, and things that could really, I think, help if disseminated, to really improve mental health broadly.
Thank you so much. It's just incredible to hear those insights most of us would never know about. Something that we're starting to read an awful lot about is just how prevalent anxiety is in society now, depression. Also, I believe Mary was saying it the other day, just how much, in part, awareness of mental illness, but just, again, it's how many are affected by it, how that's going to translate into the workforce. I've heard figures of around 200 billion in terms of what businesses are, needing to invest around mental health supports in the workplace, which are really critical. Again, people with mental health are key contributors, and often people don't even know. Individuals right next to them might have a disability. And so I just kind of put that out there.
Yeah, I think it's a really important point. Spring Health is a company that you may have heard of. It actually started by a grad student in Yale psychology. He was part of my lab for a little while. I helped him with some of the foundational work. Adam Checkrute is his name. He's their chief scientific officer. They have a $2 billion valuation, and they're the first female-led unicorn. And they're doing precisely that. They're trying to connect workforce members and companies with appropriate mental health care in order to reduce the number of lost days of work and reduce the distress of the workforce more broadly. And it seems like it's working. So we just had a paper together in JAMA Psychiatry, which is our leading mental health journal, showing that this program in a pilot phase across a number of large employers in the US worked really rather well. So I think you're right, and I think there's some hope that we're actually pushing things in the right direction.
Yeah, I think that I saw an article the other day about how much your manager affects your mental health. And those of us that are managers are kind of making a little nervous, like, whoa, you have a big effect on people's mental health. So one thing we have at MHA is called the Bell Seal, and people can apply for it. It gives you some standards as a company of things that you can do. I think it is everything from creating a really positive culture to some of the issues that were being discussed in terms of access to care, right? So you want to have all that spectrum from having a positive culture in the workplace, having good management practices, to having access to care. And I think networks continue to be an issue in terms of people being able to get access. I'm sure people on this call have tried to get someone in their network, in their insurance network, and struggled. And that's something from a public policy perspective that we continue to work on. So I think workplace mental health is very important. And like so many things, there are the preventive aspects of it, really having a strong culture, a strong connection amongst each other, clarity and purpose, and then also the specific things around access to care.
And it might be an interesting pivot. I saw a question in the chat about how do we address the country's mental health workforce challenges. So when you were saying workforce, I was thinking we were going there, but good that we went to the workplace first. I think the workforce is also a really, really significant issue here, which ties into what Mary was just talking about access and delays in people being able to get access to professionals. There's a lot going on in this workforce area right now. It's a really crucial component of this challenge. And Mary and I were both previously on the board together of the Wellbeing Trust. And one of the things that Wellbeing Trust really focused on was what is the mental health workforce at different levels. So you have the clinical workforce, but you also have a really vast community workforce that is a mental health support workforce. Really important things to think about, both different trainings that are going on for more mid-level or community health worker level professionals to be trained in mental health first aid training that's being offered at colleges and through a lot of the youth organizations. And then work going on to develop the next generation of mental health professionals. There are some programs that we're looking at right now that help bring mental health professionals who are in their licensing period into the workforce, particularly so they can work with younger people who they may be near peers with. There's a big program in California. The state is funding to expose high school students to careers in mental health, to create 350 internships for high school students whom I'm sure this is going on in states all over the country. But I do think this is another big area of focus and funding right now. And I guess the thing I would say I think is important about it is that we recognize that there are really important contributions that can be made from professionals across the spectrum, from, psychiatrists and psychologists and people with a lot of clinical mental health training, to people who have community concordance and ability to really relate to people who share their identities and share community understanding of their community and kind of how they live and what their cultural supports are that can really help with their mental health. So I think the workforce is just a fascinating topic because it also helps us explore and expose that much of this is about community and support and cultural traditions that can be supportive of people's mental well-being, as opposed to just interventions for diagnosed mental health challenges or illnesses.
Right, and you can't forget the change in telemedicine either in the last few years. I mean, I think that telemedicine has exploded in mental health. We're the highest, I think, percentage of that explosion because of the workforce shortages, and there are concerns about whether that will continue or not. State licensing is a major barrier to telemedicine continuing now that the public health emergency is winding down, and then also whether people will be required to be in person through regulations. Ultimately, Congress kind of kicked the can a couple of years and increased the Medicaid flexibilities until 2020. I think it's 2025, but they pushed it off for a while before they're going to actually grapple again with that. But it is a concern, and certainly state licensure is a concern as we now are moving past the public health emergency, because telehealth did help alleviate some. It wasn't perfect, but it certainly helped.
Great. We're also hearing, thank you so much, all of you. We're also hearing a lot about exercise and the benefits of exercise in this space. Would anyone like to speak to that? Are there, for
I can-
example, tools? Oh, and then yes, Dr. Blumberg, I'll turn to you. You know, I met the Yale, who was one of the inventors of Fitbit. And, you know, there can be such small steps that people can take. You know, you could have a device that you're wearing. You can look at if you have an iPhone, you can, you know, look how many steps, I imagine with an Android as well, that you're taking. But why don't I defer to an expert? Dr. Blumberg, what would you have to say about that?
You know, with regard to exercise, I think, you know, it's definitely one of those things on the list of things that are healthy, that can, you know, be great for mental health, for health of other bodily systems. They all work together. So, you know, it's definitely a win, you know, a win situation for health. And we have, you know, we could go into all sorts of neuroscience about the many reasons that we think it can be really healthy for the brain, the types of chemical changes and other types of things. One of the super difficult things is that when someone's not feeling well, then, you know, maybe they're feeling depressed. It can be a time when it's really difficult to exercise. And it can be difficult to say, well, just, you know, just exercise. And, you know, it can really be tremendously difficult. I think, you know, that's even potentially a part of some mental health disorders, that the energy is truly really very low. But as you say, you know, a couple of the themes that have come up, support systems can be incredibly helpful. So even, you know, getting, you know, someone that you care about out for, you know, a little bit, just getting them, you know, moving to some extent. And, you know, while, you know, it'd be nice to have, you know, these larger changes, even these small, what seem like small incremental changes are actually really big, really healthy. So to kind of communicate, it's not sort of an all or none. Each kind of incremental healthy thing that someone manages to do can be really powerful for helping their mental health, and is super important. And if it helps them to be using something like, you know, a wearable device or whatever it is that's helpful to them, that's, you know, really terrific.
Any other thoughts? Dr. Corlett, you mentioned that you had a diagnostic device. Now, is that top secret, or are you at liberty to tell us a little bit about your invention?
I can tell you a little bit about it. I just want to add one thing about the exercise, though. So we studied that a little bit in the lab. We looked at the data, and as Dr. Blumberg says, a certain amount of exercise, certainly more than 0, is good for you. But as is often the case in biology and sociology, there's a sort of strange inverted U effect, where if you feel compelled to exercise for more than 45 minutes a day, that can be detrimental for your mental health and can lead to things like orthorexia. So as with everything, you know, moderation is key. But the diagnostic that we're developing in the lab is really kind of the culmination of about 20 years worth of work, where I've been trying to find tests and games that we can get people to play, where their performance is related to and predictive of diagnostic categories and the sort of profundity and severity of the symptoms that they're experiencing across a whole host of different diagnoses. And in the company that I formed, we're translating that intellectual property out and combining it with some of the amazing machine learning work that's been happening at Pinterest. Actually, we just hired the head of ad solutions at Pinterest to come join the company and build user models, right? So far, those sorts of models that exist in all of these apps are building a sort of representation of you and your behavior based on how you engage with the website, and trying to predict what would be a good thing to advertise to you so that you'll go and buy it. And so we're using that math and those techniques to match people to diagnoses and treatments for their mental health. And it's working quite well so far. Still a lot of work to do, but we're seeing really great results.
Fantastic. Thank you. Thank you. You know, I think I'll go back to Mary again in terms of innovations. Is there anything else that comes to mind you might share with our audience, you know, relating to any of the things that have come up thus far? You know, I love the phrase happier still. And that original question, what can we do better? So I'm going to pitch that one back to you, Margaret.
Well, I think when I think about what we could do better, I think a lot about prevention and early intervention, because I think that so much of our mental health system waits until someone's in a really terrible place before we'll do anything to help. So I think that, you know, really thinking about how we get upstream is super important. And I think sometimes we can do that even by anticipating. So I'm actually going to pivot to a question that was in the chat about HIPAA and FERPA. And just to give you like an example of prevention, I really think it's critically important before a child goes off to college to have a conversation about HIPAA and FERPA, because once they're 18 years old, their rights change dramatically. But what I have found is that when people have a conversation, a lot of times someone might not want you to know everything that's in their therapy notes or what they talk about with their counselor, but they are willing to have you know how you can help them with whatever treatment plan they've decided on, right? So having that conversation before about, you know, if you experience any of these issues, to have a conversation about it at that time as well, but then also to talk about, you know, what would you be okay with me knowing? Because you can set that out for a provider and be clear about what you are getting permission to know, what you're not. And having that up front, again, an ounce of prevention is worth a pound of cure, can really help later if something goes on. So I do think that, you know, FERPA and HIPAA are important. They are important protections for people who, you know, because of the stigma and the discrimination that we've talked about, you don't want your information anywhere that you haven't made a specific decision to disclose it, right? And you also want to have the support of people in your life. And so how do we make those things work together? It's important to know under HIPAA as well that while HIPAA says to the provider they can't tell you things, they can always listen. There's no prohibition in HIPAA about listening. So I just want to be clear on that, because many times I've had families say, you know, I want to be able to tell the provider XYZ, and then the provider says, oh, HIPAA, I can't engage. And that's not true. They can listen. They can't say anything about the treatment. They can't even acknowledge they're treating the person, but there's nothing that prevents them from staying on the phone and listening. So I just want to be clear on that. So I just think that that question was, I know that that has caused a lot of stress for families sometimes, and just want to make that recommendation about the conversation. And I know providers can do a better job too. In a lot of the early psychosis programs, for example, we haven't talked about those, but it is something for people to be aware of. There are now programs around the country for people who are first experiencing psychosis, and they're really excellent programs. And they do a great job of structuring a conversation about this between families and the individual, and they're able to work out a lot of these issues through the conversation. So I just would put in a plug for those programs. If you know anybody who's in the early stage of psychosis, there's a lot better help for them than ever before. So getting to those programs is important, and getting to them quickly. And there's a treatment locator on SAMHSA's website for the early psychosis programs. But then also just to note that there are ways to address the current kind of issues that come up with those laws.
We have some, thank you, Mary. Thank you again. So we have some clinical folks with us. I always like to, sorry for this pun, pick your brains. Could you tell us a little bit about, you know, when you think about psychosis and some other conditions, you know, we've been speaking a bit to anxiety, depression, some of the sort of more often even mood disorders, you know, more often talked about conditions. Psychosis isn't one I hear a lot, schizophrenia, and yet certainly, I'm sure there are many, many people who are experiencing and living with those conditions. Could anyone speak to, when do you first notice it? Are there any telltale signs? I mean, how do you even know to go to Mary's and other excellent, diagnostic sort of sites? So, are there telltale signs? Are there even telltale signs sort of for the first time you've ever experienced depression? How do these things manifest? So I don't know, would either of you like to, or both like to tackle any of that?
Sure. I can talk about psychosis, and then I would defer to Dr. Blumberg on depression. I've been studying psychosis, which for those of you who don't know, it's the sort of departure from consensual reality that characterizes serious mental illnesses like schizophrenia, but it also occurs in the context of bipolar disorder, and then in neurological conditions like Parkinson's disease and Alzheimer's disease too. It's typically characterized by delusions, which is believing things that other people don't believe, and hallucinations, which is perceiving things that other people don't seem to notice. Typically, in the case of schizophrenia, it's hearing voices in your head, although visual hallucinations are much more common than we'd perhaps paid attention to previously. How we catch them and when they happen, they tend to happen during early adulthood. So right when people are sort of striving out independently, perhaps going to college for the first time, living alone. And they seem to be associated with a sort of precipitous drop in social interactions. Perhaps a self-imposed isolation, a turning sort of inward, spending more time than previously alone in one's room, playing video games, for example, and not doing so with peers and colleagues and friends that you'd normally previously interacted with. And then the interesting thing about those two key symptoms, hallucinations and delusions, is that they start to have sort of preludial versions of those symptoms. So not full-blown hallucinations, but perhaps feeling as though someone's calling out your name in a crowd when you're walking down the street. You're not really sure whether it's happening, but it kind of feels like it might be. Strange beliefs start to kind of crystallize. There's a feeling that, there's something more going on here. There's richer meaning in the world than previously, and kind of puzzles that you might want to try and figure out. And at that point, either a family member or a college nurse or a professor or a colleague at work might point out to you that, there's something afoot here, and that might need to be pursued. And you mentioned first episode services. We actually sort of pioneered and developed a program at Yale. We call it STEP, the Specialized Treatment for Early Psychosis program. And it's being rolled out nationally now. So those centers for first episode psychosis were sort of developed at Yale by Vinod Srihari and Tom McGlashan and Scott Woods and many others. And it seems like it works. And I think it's precisely for the reasons that we heard, that they don't just treat the individual, they engage in a pretty profound program of psychoeducation and family therapy to help people really understand what's happening to their loved one and what expectations they might have for themselves and for their loved one kind of going forward. And it seems to really help people. So I'm quite hopeful about that.
Dr. Blumberg, would you like to add anything there? And thank you, Dr. Corlett.
Yeah, and I just, want to say that, these programs that Dr. Corlett's been talking about are really important and helpful programs. So I'm really glad you had the chance to tell you about them. And I think you were asking also about what some of the first warning signs can be about depression. And I think, when people think about mood disorders or think about depression, often they're kind of thought about as kind of only emotional disorders, that you might see someone, who's sad or crying or who, articulates that they're feeling sad, but actually mood disorders can really involve a good deal more. And often it's some of the other parts of depression that can be some of the first signs of it. So for example, if someone starts to have a change in their sleep pattern. So in depression, for example, if they start to be maybe sleeping more, if they have changes in their energy, so they're sleeping more, but they still feel like they really have low energy. Kind of the, in mania, it's kind of, the opposite, where someone is all of a sudden they're not sleeping as many hours, but they're really feeling energized. We think really key components of these mood disorders are in these kind of circadian rhythms and energy. But, kind of overall, I think if there's kind of, I think, as Dr. Corlett was saying, a change in behavior, a change in something is kind of, something to look out for. And some of these things like changes in kind of overall activity, changes in sleep, changes in eating patterns, being more isolative, those are some of the concerning things.
And I'll just say, it just takes a few minutes to take a screen. So if you have any questions, you're not sure, just, jump on and do it. It's free, it's there. And I would trust your gut. Like if you're worried, if you're concerned, take a screen and see, where things stand, or go talk to somebody. A lot of people start with their primary care folks, but, I wouldn't let it go. I guess if you see a change or your gut's telling you something's going on, like any other condition, the earlier you can address it, the better. And we've certainly seen that with psychosis. It was proved. I mean, the people who got to it earlier had way better results than the people who did not. So, I would just say, don't hesitate. If you're not sure and you feel something in your gut, check it out. Because it's better to check it out and get the help that you need, or that someone else might benefit from.
I think that's such an important point. And also, if you have that gut feeling about someone that or care about, and you have a sense something is just, kind of different about them, kind of trust your gut, try to speak with them, or try to seek out some other assistance.
Yes, I think people are often surprised, those suffering, when they realize how much others care about them. One doesn't have to do something drastic, just the smallest request, even just saying, I'm not feeling great, could you come over, or, would you take a walk, or, can we talk? I don't know the perfect words to say, but I know one of the reasons we're all gathered here is because we want to make lives better and we want to save lives. I think one of the impetuses for this program for me was the loss of a friend who I grew up with and knew for decades. Just a remarkable person, absolutely engaged in life. So I guess, again, I want to thank you. We have this sort of Q&A portion. So I would invite anyone in the audience, please put in the chat some of your questions and I'll direct them to some of our panelists. So first, does anyone have the perfect words for somebody who's struggling to reach out to their friends with? I mean, do you do it text? Margaret, I think you know about AI. You can go to a bot. The bots are there 24/7, but I'm personally a believer in human connections. But again, that's some of the advances.
Yeah. What's interesting about the AI and human together, which is, I think, we've been looking at research and are working with some companies in the space, and what an AI can do, and it's used extensively in many parts of healthcare as well as all over the world, but in healthcare, to provide someone with an evidence-based or appropriate response to a question they're getting. So to the point many people have made, you might have someone who says to you, I'm cutting, and you don't have any idea what to say to them. The role that an AI can play is to give you what an evidence-based best practice response would be. And then the idea is that you as a human deliver that. And so I think when I think about what the combination of technology and humans can do, is the technology layer can be used to help the human understand what response or words might be most supportive in this situation. And there are a number of people experimenting with this now, but I do think, you know, to a point that's been made earlier, a peer supporter giving non-supportive response, you're still showing connection and love, but you might not be actually helping the person down the path. So I do think it's just very interesting space for us to continue to explore, to understand how to actually get the knowledge and evidence that's out there into the hands of the people who are, you know, answering the crisis text line, answering the National Suicide Prevention Lifeline, on the other end of all of these places that people are going to get crisis support. This is an interesting area for both.
That's so
We
helpful
had a
to hear,
study that was,
because, you know, you might have an inclination to think, to have some kind of resistance to technology. I think if you realize, you know, the sort of ethical side is addressed, the privacy, you know, certainly what you were saying about best practices is so hopeful that you could have the right kinds of things. Mary, you were saying, you know, when your sweet mate came to you and you said all the wrong things, you know, how many people feel that way, especially when working with loved ones who are just, you know, in tremendous pain, you know, suffering from depression. How do you know what to say? It sounds like one practice is never to be, to take the sort of counter position, to deny their reality, but rather to stay curious. Maybe it's to say, you know, tell me more, tell me, I'm not even sure you can ask the question. Tell me what I can do, tell me how I can help, because I think if somebody is in a very dark place, it may not be possible for them to articulate that sort of happier still place. Does anyone have any thoughts on that? And then I see we have a couple questions, so I'll go to those.
Yeah, and you always can call the 988 number if someone is in a particularly dark place and you're not sure how to help. That, you know, you can be there, you can call the number yourself and ask for assistance, and you also can hand the phone to the person that you're concerned about for them to talk with someone, because those folks are trained to have those conversations. So, you know, I would definitely encourage that, or they can even, if text is more comfortable or chat, that's available too. So just remind people that if you're at a place where you are worried about somebody and you don't know what to say, you can just suggest that you reach out to this resource and see if, you know, and explain that they are trained to be helpful. And, you know, and also ask them for guidance, because I think that's important to help someone when they're at that place.
That's a great point to remember. 988 can be for the person in crisis, or it can be for the person helping the person in crisis. And I think, again, something we need to make sure people are aware that that's available for helpers as well as for the people experiencing the challenges.
Thank you.
Yeah, just a comment that, you know, we've been talking, we've had a little more focus on the very important issues of, you know, depression and other mental health issues and suicide in younger people. Actually, some of the people that are at the highest risk are older individuals. And there, some things that can be really important issues are the isolation. So, you know, helping someone just to feel less, you know, less isolated can be, you know, very powerful. And often they can sometimes feel as if they feel what can be actually associated with high risk is if they feel like a burden. So, you know, helping with some of those types of issues as well.
Margaret, is any of the work you're doing looking at that population? And, you know, Mary or Dr. Corlett, do you, either of you have any thing to add? Because, when you think about certainly in America, and I'm not sure how it translates in other countries, but you look at the baby boomers and the sort of mushroom demographics, and I don't know what percentages we're talking about, but I imagine it's sizable in terms of the number of individuals affected.
I mean,
So-
one really interesting example, it's not something we're doing at HopeLab, but there's a company that, and I've seen a few of them, but a company called Papa that is actually now contracting with Medicare plans, which serve older people in the US. And their companion, their college student, they're kind of young people, typically college students and people in their 20s, who are basically going to provide everything from a little bit of help around the house to just companionship to older people who are struggling with loneliness. And Medicare is paying for this. And I was just thinking about it because there's an article in the New York Times today that some of you may have seen about older people who need to go to healthcare procedures, but aren't allowed to go without someone to accompany them. So all sorts of people are not getting these procedures because they have no one they can call to accompany them back from the procedure. I think it's a huge loneliness and disconnection and social isolation are huge. ARP innovation is doing a lot of work in this space around loneliness with older people. But I do think it's gotten to a place where, Medicare has acknowledged that the impact on people's broader health care and healthcare costs is so impacted by loneliness, that it's a huge problem from both a quality of life perspective and a healthcare cost perspective. So again, programs going on in those spaces, not things we're doing specifically, but ARP should have information about a number of them, and PAPA is PAPA is one of the companies that's working in this space.
Great. So I want to go to the chat here. We're getting some really, really great questions. So one has to do with relationships. What do you think people can do in terms of relationships and what others do to improve mental health? We've talked about some of these things. What particular things can people do? I think we've addressed that. And then the individual wrote, I'm the founder of a startup to improve managers and teams relationships and effectiveness by AI-powered coaches. Anyone want to jump in on that? I mean, sounds like that's sort of a big trend where things are headed, perhaps.
I can just speak very quickly to the technology side of that. I just answered that in the chat. Sorry. So, there's a company called Cognito with a K that does this with teachers, students. So there are these AI coaching for social connection, conversation, communication. And I think that is a burgeoning space for this kind of tool to help people actually learn how to have more empathetic, more connected conversations. So I think that's certainly a space where AI is being deployed. And it looks like you're starting up a coaching company to do that as well. So
great. We have another one in terms of, do any of you have any thoughts on what seems to be a proliferation of self-diagnosis among young adults and teen, based on info they find on YouTube and TikTok that may send them into cycles of self-fulfilling prophecies? Does anyone wish to speak to that? Certainly prevalent.
Yeah, I think it pairs quite well with another question about mental health literacy being higher amongst young people, and perhaps this is one of the costs that we pay when people are more comfortable talking about these issues and perhaps thinking that they might be happening to they themselves. And I think the answer is just better dialogue between us as parents and family members and friends, so that people aren't just consuming all of their information from those sites. I know there was potentially a case of sort of social contagion of OCD or tic disorder via a TikTok video. I'm not so sure that was a real thing, but I do think that people do get quite a lot of their information from these sites in quite short and often trite sound bites. So I think it's great that people are interested. It's great that they're being self-reflective. It's great that they're able to kind of talk about it. But I think the onus is on us to kind of continue the conversation and make them good consumers of that information as well, and open them up to other, perhaps more reliable sources or more traditional sources too.
There's a one pager that I think Liana put in the chat that came out today from Common Sense Media, or excuse me, a report that came from Common Sense Media on teen girls and social media sites. And there are one pagers on each of the sites specifically. I think that's in the chat. That might be there. I mean, this is a deep and broad topic, lots going on here, but that might be one sort of entry point to look at what young people see as sort of the benefits and the challenges of trying to interact with social media to get some of this information, these needs met. I think one of the things you have to remember is, while we might not want people to be going to get this from TikTok, that's where they're going to get it. So I think that what we're starting to see is more and more people who are trying to do credible evidence-based things on these platforms. Everything from YouTube to TikTok, try to think about how to get the good information out there as well. But I agree with Phil, it's a really big challenge because there's just not, there's not moderation telling people this is evidence-based and valid, this is not. And I think it's a big challenge for young people to try to sort through that.
Absolutely. And there are some increasingly efforts at the state and at federal level to address social media in youth. So California has recently passed a bill and there's more pending. Utah just passed 2 bills. And on the federal level, there's the Kids Online Safety Act, which passed out of committee last year on the Senate side. And they will be reintroducing, and it might even get through the Senate this time around. That one creates a duty of care for social media companies around some of the content, particularly in suicide and eating disorders. What we're seeing is some of the content that is, really problematic and leading to some serious harms to young people. And then also the design of some of these, the addictive aspects of the design, which are really, I know my own children, they think that they're the ones deciding how much time they're going to spend on this. And I have tried to disabuse them of that notion that, this is not something you're just deciding. This is something someone has worked very hard to keep you doing. And so I think that, there are efforts now to start looking at this. I think where we have to really be thoughtful, and we're working with a lot of young people on this, and they are advocating around some of these issues, is that there are very positive uses of social media, and then there are very harmful uses. And how do we make sure that we continue to allow the connection, going to the loneliness and all the things we've been talking about, right? And what some of the research is showing is that when you're connecting with people, it's not harmful to you. What's harmful is when you're mindlessly scrolling for extremely long periods and you're absorbing content that is very problematic. We've seen young girls search for exercise videos and get really extreme eating disorder content. That should not happen. That should not be going on. So, I think that there's going to be efforts going forward to try to work in this very difficult arena, because otherwise, as somebody said the other day, we're experimenting on all of our brains. And it's particularly concerning when you think about young people, and the number of hours we're all spending on these things ought to give us all pause.
Thank you. There's a question in the chat, and I know we're right at time. I think this will be our last one that we take, and I do want to acknowledge all of the questions that we've received. I just am so pleased with the number of people who've expressed such an interest in this topic, and we'll certainly do other programs on it. So this question is a challenging one. Essentially, it's, what do you tell? How do you get someone who's, dangerously addicted? It could be to alcohol, any kind of drugs, any kind of substance abuse, so that they are encouraged to appreciate the dangers. I'm not sure about encouraged to appreciate. Maybe it's just to recognize how much better their life might be if they could change, and what could be done to affect that realization, and different steps that could be taken. I don't know if that goes back to Dr. Blumberg saying that it's small steps are a good path. You know, I don't know when you decide an intervention is necessary. I don't even know how people do that. I don't know if that needs to be a next of kin, a parent, can a friend do it? It probably matters whether it's a child versus an adult. So I guess this is a big one, but we have the heavy hitters here. So anyone who wants to take it, please feel free to.
Well, this is not my area of expertise, but my sense is that intervening often and through various different sources is often successful. You know, we talked earlier about there are no magic words. I don't think there's a magic bullet in this situation either. I think trying your best to get the message across from various different people who may have or may carry different amounts of weight with that message, right? Hearing from your children, hearing from your siblings, hearing from your friends, the ways in which you've changed, and also the ways in which your behavior is affecting them too, can be extremely powerful. But unfortunately, until you try, I don't think there is a perfect way of doing it, and actually just taking the first step is really important.
And we do have a screening test on that, and so if that's something the person's willing to do, to start the conversation, to just kind of look at how they're answering some of those questions, it might lead to some insights. But I also completely agree that, you know, having those conversations and then also using any tools that you can to sort of aid with that discussion.
Well, I want to thank our incredible panelists. I'm just so humbled to be in your company tonight. I've learned so much. I imagine our audience has too. I feel like I've been sitting on Mount Olympus for a while with, you know, the gods who really understand, and not only that, are, you know, so committed to helping, you know, so many people who are struggling, and to bring hope and light and you know, positive difference to so many lives. I hope, again, perhaps some lives have been saved tonight, not just through the work that you're doing, through the conversations that we're having, but also through the Herculean work that families, friends, individuals living with mental health undertake every single day. So thank you. I hope you'll be willing to come back for another program. And I hope you all and the audience as well have a wonderful evening. Thank you.